So often you'll hear at the chiropractor, well, your knee issues are probably a result of either ankle mobility or lack of hip mobility or maybe instability in the spine. What is the trouble with this knee joint, and why do we focus on adjusting the pelvis and increasing our hip mobility to help out the knee? A lot of it comes from either torsion, so we could have maybe like there's a twist one way over the other, and that's usually doing that because imbalance in the muscles, right? So we got a lot of different muscles inserting. We'll try to talk about them. We kind of see a good overview here, because here we have all the muscles. We got the hamstrings coming in. Hamstrings, they're mainly go into the back of this tibia bone here. Some are attaching to the fibular bone. And then we have the quads, the big ones moving in the front, attaching into the kneecap. You can kind of think of them, I like this picture here, where you have kind of the vastus intermedius, which is below your rectus femoris, kind of a sheath of tendons spearing your patella. It's just kind of, there's like a joint there, but it's kind of like a long tendon just going down, and this attaches onto our tibial tuberosity. So they're both pulling on the tibia, if you want to think about it that way, just from different directions. So we're thinking just levers here. So we have one lever that's pulling harder or stronger, more activated, and then you have an inhibited tension muscle that's weaker. It's not going to be doing its job. So then you have a structure that's compromised. And we just know with like the spinal joints that if there's uneven stress, even just thinking in this plane, this one's pulling harder this direction and this one's not, it's giving in. So we have an uneven strain on the knee, and the joint will respond with arthritic changes because it has to. It's going to add calcium to the joints to stabilize, try to lock the structure down so tendons don't tear, and so meniscus doesn't get hurt, and a lot of vital things in there, including arteries and nerves, right, that pass through these knees. And then we can start thinking of torsion, right? So we talked about the tibia being twisted. So let's say like the outer quad is tighter, vastus lateralis. It's kind of inserting a little more laterally onto that kneecap. Sometimes we'll see the kneecap pulled off to the side, right? And so lets me know, okay, we got an uneven pull from maybe that muscle, or maybe it's the hamstrings coming down here, causing the tibia to twist. Could be a lot of different things. But we kind of have to think upwards, right? Think about what this hip is doing. So a lot of us have either anteroversion or retroversion, where this means is, I like to just call it, it's externally rotated or it's too internally rotated. And then we have to start thinking, all these hip muscles are now playing a role. And the other one that's not really on here we can think about is, because of all the quads, the only one that actually attaches to the pelvis is our rectus femoris, which overlays a lot of the muscles you're seeing here. So we have this ASIS in foundation training. That's your muscle where you're doing your measuring stochastic. So you're lengthening, you're activating your big psoas muscle. Psoas attaches here. That lesser trochanter goes up, attaches here, goes up to the discs, spine, and it forms this big protective muscle, which helps what? Kind of hold this in the socket like it should be. So if we have a twist where it's externally rotated, we have some strain on this psoas muscle, this iliacus muscle, which should be kind of helping hold this firmly in the socket, just like your rotator cuff would do. That's its job, is to hold your humeral head in the glenohumeral socket. Sometimes it's so restricted there, it's so twisted that I'll see people using their scapulas or their spine, a lot of flexion extension to get that motion. And they can even have really great shoulder motion and have a lot of restriction in their ball socket joint, just like in the shoulder. Same problem down here in the hips. And so when this happens, and this isn't moving well, we can just think, well, this isn't moving well, so the knee now has to do a lot more. So it could be a lot more of this, which is our flexion extension of the knee, or it could even be the rotation of the knee. And your knee, maybe it has 30 degrees rotation either way, not a big mover. It's not supposed to be doing that. Where your hip should have a lot of that motion, be able to internally rotate a lot, externally rotate a lot to handle these stresses. If it's restricted, this is going to start doing more of the work. And same with your ankle. Oftentimes the ankle just doesn't get a lot of movement. And then the ankle gets very stiff, and then the knee again is trying to do a lot of the work. So let's quick look at the hamstring now. We talked about where the quads go, attaching this ASIS, big, quad, 4 muscles, right? Hamstring, 4 again. The little one's tiny, hides over here, attaches mid shaft. But otherwise, they're all attaching pelvis, your sit bone. Bone you sit on, hamstrings come down. We kind of talked about this sheet of tendon and fascia that comes down here. The hamstring has the same thing. So it comes here and it shoots up right here to the sacrum. This is our sacrotuberous ligament. So we have a big attachment to our tailbone. And that's one thing that the quad is kind of lacking. It comes here to the pelvis, but it has no real insertion into the sacrum. So hamstring, very important muscle in that aspect that's able to attach to our keystone, really. So a lot of hamstring tension, a lot of tightness that sometimes goes hidden. And the way we hide it, if we look at this person here, their hips are what? They're back. If they were standing here, they'd probably be kind of stacked if you think about it. It's a straight line, their ear, their shoulder, hips, kind of in a straight line. They're running. A lot of people have the opposite problem. They're standing or they're running and the hips have swayed forward, and that automatically will tuck the pelvis. So people have this posterior pelvic tilt. It's this tucking motion. Sometimes you'll see it just at the bottom of a squat. Sometimes you even see it when they're standing, but they like to hide it by swaying these hips forward, which brings the rest of the structure backwards. That creates uneven stress on your lower lumbar spine and your sacral joints here. These important discs that are doing a lot, they're holding a lot of your weight, so that shoves the discs forward, and both pelvic bones have essentially dropped down and back and forward. And sometimes the sacrum will do the opposite motion just to counter that. So some hidden hamstring tension. And that's going to pull the tibia backwards, right? Because it attaches down here. And that's going to create a shear force on the knee, where the quad is not doing enough. And it's not that you should be going and doing lots of quad exercises. It's training the body in the right position. We need to get the hips working, and we need to get it working with the spine decompressed. That's our opening up. And what muscle does that best? What is the greatest muscle to hold that stability in the lumbopelvic region? That's your psoas here. It comes in, helps hold that femur in. It helps secure these SI joints in a locked position. So when we're doing our hip mobility exercises, which we do all day, even sitting, I'm sitting right here, I'm using my hips, I'm lifting my torso up and stacking them. That's psoas engagement. Even though it's subtle, it's enough. If we're compressing and my head is going forward and my spine is flexing or extending to do a lot of the work, that's a problem either way. No matter what posture type you are, people flex or extend out of it to try to cheat, when the big cure is trying to think of load tolerance, right? You're always lifting your skull. The more you kind of lift, it neutralizes pelvic tilt. So a lot of people just break this down. They're like, well, it's either posterior pelvic tilt, or we could even say this guy looks like he's quad dominant, right? Because he's running, right? So it's anterior pelvic tilt. So it's the athletic hip. Or the quad is pulling that, and remember, there's only one muscle there that's really, well, there's other muscles right here. We got sartorius that comes here. Sorry, that's probably like the inferior. That's not your ASIs. There's your ASIs. Pulling at sartorius kind of wraps around too. Of all these muscles, gracilis kind of mid shaft, but you do have some pelvic muscles and these adductors here that help support some more anterior tilt, help prevent it from getting pulled backwards, right? So we got the pectineus, adductors, very important. Gracilis, very important. A lot of these we're engaging as well. You see how they kind of flow if we had a psoas muscle here. Kind of almost an extension of it. And that's a good way to think about muscles. Don't think about like individual muscles or just your quadricep or just the rectus femoris, but how muscles blend into other muscles and form stability with the body. And then when we start thinking about that, it's like, well, we're not really isolating anything. We're working everything together as a whole. One little thing we've been teaching in foundation training is how we have these big kind of X's throughout the body, which help secure. They kind of cross right over that sacrum and this thoracolumbar fascia, which is a little higher than here, that everything kind of inserts to. So we have these big X's that hold and wrap and force close these SI joints, hugging that sacrum. And then this secures stability here, so we could focus on mobility here. Once we do that, we will help the knees. So hopefully I've created enough crazy arrows here to confuse you, but hopefully that helped a little bit, give you an idea that, yes, we should work on the hips to help the knees. Foundation training is a good, safe place to start with that. There's other good programs like knees over toes, something that's a little too much to rush into right away. But if any of that hurts, just work on the basic steps first. Even with foundation training, a lot of people are just starting people with breathing. Why am I starting them with breathing? Great iliopsoas activation, trying to train stability before we even think about mobilizing, because we've so trained our spine to do the mobility and the SI joints to do the mobility that the hip no longer knows how to move right. So we first have to create stability here so we can better focus on the trochanter moving. And I've been giving some people some trochanter belts to help squeeze. Help squeeze these guys down. Hold them, lock them, secure them. Have a great day, guys.